Bienvenue à cette discussion qui portera sur les avancées pour les cancers du sein métastatiques. Pour cette discussion, je vous confie aux soins de nos deux intervenants. Je vous les présente maintenant, Dr Sarkis Meterician, professeur titulaire en chirurgie et oncologie Université McGill et directeur du Centre de cancer du sein du CUSUM. Bienvenue. Et Cédric Baudinet, directeur investissement et promotion de la santé à la Fondation Cancer du sein du Québec. Merci.
Merci Martine. Bonjour à tout le monde. Bienvenue sur cette entrevue avec le docteur Meterician. Merci Sarkis d'être présent aujourd'hui. Juste pour refaire un petit tour de la situation et pour les personnes qui ne sont peut-être pas touchées par un cancer du sein métastatique mais qui aimeraient avoir plus d'infos là-dessus. Le cancer du sein métastatique, qu'on appelle aussi stade 4, c'est le stade de cancer du sein qui est le plus avancé. Les personnes qui en sont atteintes font face à une réalité qui est bien différente de celle des autres stades. Et à la Fondation Cancer du sein du Québec, on en est bien conscient. C'est pour ça qu'on propose une session qui est dédiée. Et aussi, j'en parlerai un petit peu à la fin, des services spécifiquement dédiés pour les personnes touchées. On estime environ, des petites statistiques très rapidement, que c'est entre 3 et 10% des nouveaux cas de cancer du sein qui vont être diagnostiqués d'emblée, donc de novo, au stade métastatique, et on estime aussi que c'est approximativement entre 20 et 30% des cancers du sein qui vont le devenir. Alors aujourd'hui, Dr Meterician, pour discuter avec moi des avancées justement sur les cancers du sein métastatiques. Puis, docteur, la première question, tous les cancers du sein métastatiques ne se ressemblent pas. C'est quoi les différences qu'est-ce qui va les différencier?
Oui, Cédric, on a plusieurs critères. Par exemple, le cancer du sein, comme on sait, peuvent aller dans les os, le foie, les poumons, le cerveau. On sait que dépendant de où ça va avoir des métastases, on va changer le traitement. Deuxièmement, on regarde l'intervalle entre la première diagnostic et les métastases. Naturellement, une femme qui a eu un cancer il y a 15 ans et les métastases aujourd'hui, ça va aller beaucoup mieux qu'une femme qui a un cancer aujourd'hui et développe des métastases dans 1 an ou 6 mois. Là, on est un peu plus inquiète pour l'agressivité du cancer. On va regarder, comme on a discuté tout le matin, le moléculaire du cancer et naturellement l'âge de la patiente, parce que l'âge de la patiente va influencer les traitements qu'on peut donner, parce que les traitements qu'on donne ont des effets secondaires.
Donc vraiment plein de caractéristiques différentes.
Oui.
Aujourd'hui, le plus gros défi pour le traitement du cancer du sein métastatique, c'est quoi?
Bien, le but quand on voit un patient avec un cancer métastatique, première chose, c'est d'être certain que c'est métastatique. Parce que, comme on sait très bien, quand on fait des scans des poumons, même moi, si je faisais un scan de mes poumons, on aurait trouvé peut-être des petites nodules. Et naturellement, nos patients s'inquiètent parce que tout le monde a des nodules dans les poumons, je vais être honnête avec toi, et quelquefois, on essaie de voir des scans une après l'autre pour être certain que c'est vrai, première chose. Deuxième chose, c'est de là décider quel traitement on va donner, parce qu'on ne veut pas...
So we don't have, we don't want to have side effects that would affect the quality of life, and we want to increase the survival, especially in order to find balance. And of course, you talk about quality of life and the benefits for the metastatic cancer. When we discuss with our patients, we talk about the survival with no progression and the global survival. But when I talk to my patients, I say, okay, we want to present the absolute advantages. Sometimes we're so excited because of the results But the question by the patient would be, what are the side effects and the absolute amelioration of my survival? If they say 24 months and I am going to increase to 30 months, this is an augmentation of 24 months. But they say, okay, with this, is it worth doing this treatment? And they do have this a discussion of the benefits, because we want the patient to take informed decisions for the metastatic cancer. It is also the quality of life. It is something that is important today, and how to measure quality of life. This is a good question, because there are some studies that are going to focus on the quality of life with a questionnaire, and how is it going for the sleeping and the quality of life. And some people would mention only the side effects. We know our patients and we know their age. We know everything about them, or many things about them, but on the side events, we see that we're not sure what is going to happen. So is it for 70 years? We will see a lot of difficulty, and for 40, sometimes for 40-year-old, it is not working really well sometimes. So it depends on a number of factors. But Nabil mentioned this morning, say, okay, there's this uncertainty, and then we don't see the balance, impact and benefits. But this is the question in the center, to see what is the quality of life of the people. We also will see the different the tools for the metastatic cancer, immunodependent. So we have the treatment at the level of therapy. Yes, for an hormone-dependent. Hormone dependence is a cancer that provides these problems from 10 to 15 years after getting the cancer. So the triple negative and the HR2, they had this, we see the effects or the problems after 2 or 3 years. But then when we see that in 10 and 15 years for hormonodependent, for the metastasis cancer, we know that a woman with this, they can survive. I've seen these, and they are alive 10, 15 years, and they are doing well with no problems. The first choice in this cancer is the medicine with hormones. They have received this when they had their first cancer, and sometimes we want to change that medicine. We see only a few side effects, and it is this is the first choice. And then recently we see the SEDAC or SEDIC inhibitors. We see that they are, this is for Perbo and Ribo, we see it in these studies with combination with anti-hormonal. So it depends on the patient and the age and the number of metastases and the preference to start with this medicine and Ribo with this anti-hormone. And this is something that how does it work? This medicine, because the cells are always being divided, and they will block the division of cells, and they will block the dead cells. So, and this in the metastatic HN2 positive, they have a very good HR2 positive is this cancer that patients are finding difficult to understand, because they have we see this HEL2 positive, what does it mean that this increase? We know that your cancer is more aggressive, but at the same time, what we see as medicine, we have a lot of available treatments for HEL2 positive. Sometimes there's metastasis, but we have so many different treatments that we know that we can make a difference. And the choice number one is to know what they have received when they had the first cancer. And sometimes they have just this tumor, and they are going to receive the pertuzumab in combination of the trastuzumab. Or we are going to provide other choices, the TDM1, or in another. We also have another sort of medicine that are available on the market. So we have so many, a big deal of choices in order to improve that. We have also Azure to Low, and that is there. And could you please, when we have the biopsies, we can test this. We can see if it's positive or not. I mean, sometimes it is just one or two, and then especially these two, they are not positive, but they have this expression. When we see the pathology, we have shown that we have this medicine that we can provide that are against this catnip, and they can be effective. So if we have an HL2, if it's a negative, we have other available choices for them. So this is the 2 degree of their expression. They are not very positive in order to be targeted, but it could be negative. If we understand what is the cancer, if we have the number one advice would be go towards clinical research, because in clinical research, this is something that we are going to see. If we are going to know if the medicine is effective with McPick, and we are going to try new medicine that might be effective. It is there where these and most studies are for metastatic cancer. So for the triple negative, is there any, for this type of cancer, it is more aggressive. For the triple negative, we've seen some difficulties, but now we have a lot of hope because we see new medicine, new drugs. And we can measure the PDM1, and that is an antigen for the cells. If they have seen that, we know that they are going to respond to immunotherapy for the cancer, metastatic, triple negative, and this is first of all studied in the metastatic cancer, and for the neoadjuvant. We know that immunotherapy is going to work. And we know that the triple negative is one of the cancers that are going to be the genetics more than the others. If the woman was not tested, then it is time to do that, because there will be a CR2, then we can provide the inhibitor that are the drugs that are going to kill the cells. They are not going to repair them for the DNA. So if they have that, then the PD-L1, then we can provide the immunotherapy. We have the choice, and also the clinical studies for the triple negative. And now when you say that, is this, we talk about the anticorp. What is the antibodies, conjugated antibodies? They are not effective. So they favor the input of drugs in the cells. And there we see sometimes that the medicine is not effective. And then the cancer cells sometimes are smart, and they have developed the protection mechanism against the medicine. And these cells are going to try to penetrate the cells in combination with other factors, and they will try to increase and they will have a lot of opportunities to die. So we see this. This is systemic, then yes. I think we've already covered that. Maybe we can talk about the research, because you said that you wanted to mention that. In the initiative, this is the register, Quebec Register of Metastatic Cancer. Yes, first of all, in Quebec, we don't have a register for cancer. And here in the hospitals, we have that. We ask the question, and then for women with metastases, we have the pharmaceutical companies for this use of the medication. And so there's probably one woman in Quebec and in Sherbrooke who has received that, and everything is good, but we don't know. Yes. And then we talk about the medication that is not accessible, right? And for the register, we had this idea, why not going to see the patients, real-world evidence. So these are the data, and the use. Just in a moment, I am going to write, we have these 10 hospitals that are going to say that. And CHUM, Sacré-Cœur, St. Mary's, the Regional Hospital Center, Sherbrooke University, and Chicoutimi. They are part of this initiative. We have 737 registered patients, and for the pharmaceutical companies, they have funded this register, because in the pharmaceutical companies they know that they don't know this data, and they know that they have HR2. You can use the other one in Sherbrooke. There we are going to capture, we are going to know if that works or not, and this provides hope, because if somebody uses it in Sherbrooke, we will know, and this will be known by the medical domain, and they will try it. Of course, this is also the question, what is the survival? We know the data, but in Quebec, we're going to know it. We're going to learn that. We will see the side events of the medication. So I think this is an opportunity, and we will see more. Almost 1,000 patients, and these are the data that are going to help women. This is the real life data. Also the data on quality of life, maybe? Yes, because it allows us to have, we will see the clinical trials. Because in Quebec, and we will see, we have seen some presentations because it is not accepted by the government. But this medication can cost a lot of money, so we ask the pharmaceuticals to give us the medication, and then we're going to capture the results. So if there are people here, we will see how to participate, how to contact the centers, the health centers. We will see that this is so sure. We see that is going to increase. The same thing for the hospitals. We approach the patients, and they are not going to help the patient who is going to have this metastasis. And they will know what has happened to the patients. Yes, maybe you can find people that are there. Yes, if you're part of this center, then do not hesitate to contact your medical team. Marcy Serkis, we are going to take some time for the questions. It is difficult to answer the questions, very specific questions, but you can ask questions. Could you please talk about this type of metastatic cancer, oligometastatic? This is a very good question. For the oligometastatic, that means that the patient uses only that part, one metastasis, and this is only once. So this is only one part for the brain, for the radiotherapy, stereotactic, and also the lungs. And we also have the surgery. When there is one woman, I talk about the brain and the lungs. So we have this part. Maybe this is going to go to oligometastatic. So we are going to repeat that. And after 1 year, of course, this is oligometastatic. We also have one injury, and then that's it. With the experts in the hospitals, maybe we provide this radiotherapy. Hola, est-ce que tu peux venir, s'il te plaît? So if we have that, we can offer that part. It is very interesting. We've seen the cancer with the virus. This is the HPV. And we have this also for the cancer of breast cancer. And we have two phases. First of all, no. We don't have anything. We have the clinical studies. We have one. And then we will have also the vaccine. For the vaccine, with the antigen, with the immunotherapy in order to change that part. 1 and 2, we are going to see that, but we have that part, and then we can use the immunitary system in order to treat the patient.
A part of the immunity is what I call the janitor that's not doing his proper work, and so they go up and they don't see. Now, immunity is key. I also find that with the COVID, the door was open wide, allowing us to understand immunity and the inherent details and the subtleties and the subtleties. Apologies. Hello, thank you very much for this intervention. I have 2 questions. The first question is on the metastasis diagnosis. So at first we're in control of things, but then I've just arrived here to the country, and the exam that was prescribed was the mammography. But when we're talking about metastasis, is metastasis in other organs? Is there a way to prevent things such as having preventive diagnosis? Because wouldn't it be not interesting to discover it in an organ instead of having it disseminated in other organs? And so you've also spoken about the survival rate. I've heard a lot of researchers say that when we have an illness, it's better to listen to the diagnosis and not the prognostic, because indirectly we are programming our subconscious mind. And so when we are told you have 6 months left, the person says, I have 6 months. And so it's as if they were also programming their body to live 6 months. Yet, if we tell them that this is a chronic illness, that you can live with it for more years, and so on and so on, one helps the patient live longer. I'm going to answer to your first questions, and I'm going to ask, and I might answer the second. As for the first question, there are many studies, and that is how we teach our residents and our students, is that the question, and the patient often asks me, doctor, as they have stage 1, stage 2, they ask, do I have any metastasis? The problem is, as a doctor, like everything we do in the medical world, we have to balance the chances of us finding something aligned with the anxiety, the side effects, and the exams. And so when someone comes to us and has a cancer that is lesser than 2 centimeters with positive lymph nodes, we don't make a metastatic exam. If you ask me, if I wanted to, unfortunately, science is not guaranteed at 100%. Someone may have metastasis, and then you can't have one, but we can't have 99% of our patients do exams that would not come up with anything. But once we conduct surgery and that we say that the lymph nodes are affected, that becomes a stage 2. Therefore, a metastatic review and report has to be submitted. Yes, you are right. Sometimes the patients will ask us, why aren't you conducting more tests? In my humble opinion, I can tell you, I've been treating cancers for 30 years, and I have the same worries as you. If we conduct tests and then we discover something, what will happen? And I don't know. So I'm trying to have a theoretical approach. If a woman is being followed up for a stage 2 or 3 cancer, we're not going to talk about stage 4, because stage 4 means that it has to be followed up with blood tests and consequent exams. For those who do not have any metastasis, we will draw blood and conduct tests every 2 to 3 years. Depending on this blood sampling, we'll try to see, do you have any pain in your stomach? Are you coughing? Do you have headaches? Everybody has headaches over here, so it's very difficult to determine whether or not it's a factor within the interpretation. Sometimes, I don't know, we're going to try to do a scan. But the follow-up for the patients, unfortunately, in 2024, doesn't have anything that can detect a cancer today that would be microscopic in the liver. For us to understand, to get it, it has to be of a minimal of 1 centimeter. Unfortunately, we don't have that, but I would like it, just like everybody else in the room. We want tests that can detect those cells. The country where I was treated, in the country I was treated, my oncologist has prescribed a PET scan for life, and I did it for it. But isn't there not a risk isn't there a risk to exposing your body to different X-rays all the time? No, not if you don't do it correctly with the mammography. Maybe 1 or twice a year, there's not going to be any problem with it. With MRIs, there are some possible damages because of the injections of linium to for the brain. But then again, 1 or 2 times a year is not a problem. Once or twice a month, that would be a problem. Now, there are no oppositions to X-rays, but I do have a little bit of a caveat, because how are you as a woman going to conduct exams every 6 months? So these tests are not available. We only have the CA 15-3 in order to determine or to find metastatic cancers. But it's not as good. For the second question, it was a question or a comment. It was because in terms of the prognostic, when we announce it, when we give somebody a prognosis, we tell them you have 6 months. A good doctor will never let you know or tell you how many months you have left, because we are not God. Oh, sometimes we'll say, oh, there's going to be a metastatic. We tell her she has 10 years and then she ends up dying 6 months. Or we tell one that you have 6 months left and we see that they live 10 years later. So it is not ethical, and we do teach it to our residents, to never mention the number or tell them, oh, you have stage 4, we're going to treat you. While we discuss about the treatment, we tell them, would you want to be treated? This is the treatment, X, Y, and Z. These are the side effects. Let's go. But if they ask me, what is my survival rate? I don't know, ma'am. We'll see. We will follow up with you and we'll discover that together. Thank you very much. Let's just take a last question. This is the last question because we are running out of time. So we'll finish with that and let you go on the other side. I was trying to see if there were any... apologies. I wanted to know if there were any research or if we had any data for patients that are NED, no evidence of disease, if there are any studies, or do we have any data to that effect? No evidence of disease. When I see a patient and I see that there's a negative, there is a negative result, I'll say no evidence of disease, and then I'll tell the person to go back to the clinic in 6 months. In a case of a metastatic cancer, that's what I meant. Oh, you mean like the person has had the metastasis have been discovered, and 6 months later the person doesn't have any cancer? I've had example of patients who are living with a metastatic breast cancer and they live for years, and they're after 6 years are declared NED. There are such patients. That is the goal of the metastatic treatment. Our impression is that a woman is never going to be an NED. I'll never tell that to my patient. I'll tell them, listen. Madame will tell me, do I have metastasis? I said, okay, it's going well. We're not seeing anything. But my patients are pretty intelligent. They know. Because these metastases are microscopic, but the cells will be dormant. Oftentimes, the patient will ask, hey, how did it happen? I've had my diagnosis 15 years ago, and now I have metastasis. Unfortunately, cells stay dormant for 15 years. they will come back, and then after that, they will end up having a negative result. So, example, we have to follow it because these cells maintain and stay in the spinal cord and in the spinal marrow because we don't know when things are happening, and thus we have to monitor it. I'm so sorry for not answering the rest of your questions. We're running out of time, but I'm going to resume. I'm going to review what you said, Doctor. So there are more researchers in the metastatic cancers, and under each type of metastatic cancer, there are different types of technologies. As we compare things to 10 years ago, we now know that the metastatic breast cancer is not a death sentence, the one that we would hear before. It is something that's in evolution. We want to consider it as a chronic illness. The participation in clinical trials is good so that you can get access to excellent quality treatment that we will test to see whether or not they're better than the current testings or current treatments that are proposed. But also, this participation is also beneficial to the others who are also ill. Thank you, Dr. Messiaen. And just to remind you, there is a QR code on the screen that is the link towards the Foundation of the Breast Cancer in Quebec, and that is the link to the specific page. Services are proposed, and they're dedicated to those who have breast cancer. All our services are open to all, regardless of the stage you're in. Now, on the website, you'll see that there is some very specific information for those who have cancers at different stages. Now we have to know that we have the money invested, depending on the stage, is different. We also have a Club Jazette, which is a discussion group. We also have a Facebook group called Parlons Stade 4, Let's Talk Stage 4, where you can exchange with people who are going through the same reality. Don't hesitate to scan the QR code. And I thank you for your attention, and we will reconvene in the big room for the rest of our activities. Have a nice day.